It is a distinct pleasure to invite Mike Weinstock here to do his Bouncebacks talk. I am fully taking credit for putting his 3 kids through school because I have bought every edition and given those out through to all of the administrators and quality assurance people that I've been involved with through the years. I encourage you to do the same. It's a terrific book and product and CME as well. So with no further ado, Mike, come on up. And Shelley, are we going to come up and do this? So for all of you looking for 50-50 tickets to go towards 100% towards EMAF, you find Shelley McLeod. She'll tell you. She'll steal all of your money from this. And I'm starting it off with $100 worth of tickets.
Woo! Big spender,
yeah,
big
spender.
100% of the proceeds go to the Emergency Medicine Advancement Fund, which helps fund Canadian emergency medicine research. Not only do you get the money, you get the cape, and you can bedazzle the crap out of that thing. Thank you, Connie LeBlanc. All right, so let's make the magic happen. Ooh, just that easy, folks. Just that easy. Oh.
Hold on, sorry. So Shelley's going to have to leave us, and so I'm going to take over ticket selling as of this evening. And I just thought I would show up Sean. So I'm going to double his, and we can double down and go with 40. So whoever wants to one-up me, right, come find me or Shelley later. So.
Okay, so hold on. We're going to do this. We have, oh my goodness, that's 40 tickets, $200, and just that easy.
It's just that easy.
Make the magic happen.
There it goes.
Done.
Okay, and for those of you who aren't familiar with Bouncebacks, this is the book up here, and I believe you're going to be making some of these available to various members of the talk here. It is well worth it. I have read it cover to cover and many times over. No further ado.
Well, thank you so much, Sean.
Welcome.
Yeah. I will say I'm honored to be here. It's really nice coming from down south to do this. I did put on my rider that I was going to get a cape, and I haven't received it yet. So, maybe just next time. But I did get a T-shirt though, which I'm honored to wear, and I'll be wearing that on my way home tomorrow. So, what I want to do today is really have some things that you can take specifically back to your next shift. Some things that you can do that will hopefully change patient care. And we're going to be doing 2 different parts of this. The first will be a shorter segment, which we're going to talk about a specific differential. And for folks who have listened to MRAP and have listened to the UC Max podcast with myself and Gita Pensa, we have one of our segments called If It's Not in the Differential, I Want to Be in the Diagnosis. And that was also one of the things that Joe Sachs, one of the producers from the show The Pit, put on The Pit just recently, which was quite an honor to me and really fun. And he did that, and he called me and said, hey, look, just listen to this episode. We got something on there for you. So that was pretty cool. I'm also going to keep this interactive in the sense that we have 3 voluntolds that I'm going to call up here in just a few minutes, who are some of our own emergency medicine residents here, and they're going to sort of help to participate with this. But we also have a couple other trivia things that we're going to do through the way, and we'll be giving out some bounce back books at 2:45. I have a little it's like a, I don't know, in all humbleness, I think billed as like a meet the author type of thing in the showroom over there at the CAEP booth. So happy to see anybody that wants to come by. I've got a list of some interesting quotes and different things, so we'd love to have you there. But anybody that actually answers some of the trivia, we'll let you pick out a book for that. So we have a bunch to give away. So in all of that being said, I want to just sort of start with this first section here. And when we think about, how we can get tripped up in emergency medicine, and we certainly can, and that statement that was in the flyer, or I should say in the agenda, if it's not, the statement that was in the agenda where we talked about, remember that patient that you saw last night. We all have that. In the United States, we can scare people by talking about medical legal stuff. It's not as important here, of course, but what is really important is getting it right, because not in a depressing way, but we will all be, patients or have family members that are patients through the course of our lives, right? We want to make sure that everyone is treated as good as possible, right? And so sometimes there is just a very subtle thing that can happen. And we're going to tell some stories. There'll be a top 10 list of some really important things to do on your next shift. But before that, this part here, I have this little approach that I've talked about called the front door, back door approach. And it's really pretty basic. I mean, it's probably stuff that we do all the time, but just sort of formalize that type of name. And when you think about the front door, it's really a symptom-based approach. So for example, say you have a patient with, chest pain. You think about, the onset or the location or what makes it better or worse, all those types of things. But then the backdoor approach is thinking about any type of complaint, not from a symptom-based part of that, but more from a diagnosis base. In other words, what could be going on with that patient as you send that patient home where they could end up in 24 or 48 hours cold and horizontal, right, i.e. dead, right, something that we may have missed, and maybe accounting for that before they leave. There's something that I call the 3 R's, revisit, record, and recruit, where we can actually, when we're thinking and maybe cognitively doing a little bit of a hard stop during that medical decision making at the end of the encounter, thinking, well, what could I have missed? And maybe what could I account for? So you don't really know that until you understand what the differential is on any certain patient. So the front door is a symptom-based approach, and this is one way. There's code years. There's a lot of different ways that you can do that. And for medical students sort of learn this. When you're residents, you sort of forget it. And attendings, you think you're too good for it, like myself included, all of us, right? So I say that not in any sort of like way beyond just a self-deprecating type of way. But in the end, when I think about, and this is, again, in the States, but the cases that I've gone through at peer review or medical legal cases that I've gone through, the biggest fallout on those cases is not gathering an adequate amount of history. And we're going to show a really good example of that with the devastating outcome of a 39-year-old woman where a better history could have made all the difference in saving this patient's life. Okay. So the front door approach is symptom-based. The back door is thinking about things in a diagnosis type of perspective. But what I want to talk about today, and this will be the shorter part of these 2 different subjects that we're going to be looking at over the next hour, is a differential for a patient who presents with a headache after a negative CT scan, where they sat the patient up and did a lumbar puncture, and that came back negative. So probably you guys could think about this in the same way that I would think about it, as you're going to see your next patient, and you talk to the nurse, and he gives you an eye roll, and it was like, the patient was just here yesterday. They had every test known to humankind. They had a CT. They set him up and did a lumbar puncture, and they haven't even tried acetaminophen or ibuprofen, and now they're back again. Right? You all have been there. I've been there too, right? And you walk in that room with a little bit of a bias to think to yourself like, yeah, this patient, maybe it's a symptom magnifier or something else, but I'm going to give you 8 things, and there'll be a little bonus one thrown in. So 9 things really that could still be going on even, and these are can't miss type of things, that could still be going on even after a negative CT, a negative lumbar puncture. But the really cool thing about this exercise is all of these things can either be diagnosed or strongly suspected just with your bedside evaluation alone. And when you think about it, like any of us, when we went into like an interview for medical school, why did you want to be a doctor? Well, of course, to help people, right? It wasn't really for documentation and throughput, of course. So when you think about, I actually said documentation and throughput, and the person that interviewed me said, look, you're not that smart, your grades are terrible, but you're the only honest person that's come through applying for medical school, so we're going to accept you. So I'm just saying it's good to be honest sometimes too, right? So to do this, I'm going to actually ask for some folks to come up and help me. And we have Fadi, we have Tegan, and we also have Marissa, yes. And they are emergency medicine residents. If you guys want to have a seat here in the middle, and we'll go through things, and I'd encourage everyone to sort of like work with this also. So this will be sort of fun and interactive, and in case you're scared for them, this is all like a safe space kind of thing here, so all good. Okay, so what I wanted to do is, before we go too far, where are we at on that slide? Okay, so what I wanted to do is think about this differential of patients who, oh my gosh, you guys can see the answers here, can't you? I did not realize that. Do not look, do not look. Maybe we'll delay the slides by 1. Okay, so why don't we start with you, Tegan, right? Okay, and Tegan, where are you from?
Hello, I'm from Winnipeg.
Okay, oh, you're from Winnipeg?
Yes.
That's great. A little trivia, not that anyone cares. I was here in 1989 for the Winnipeg Folk Festival, and I heard last year was its 50th anniversary. It was 4 nights. I'm still catching up from my sleep from those 4 nights. So I love Winnipeg. I was so excited to come back. At any rate, and you're in residency now. What year are you?
Yeah, So I'm in third year of the 5-year program.
Okay, gotcha. All right, so Tegan, we have a scenario here of a patient, we'll say it's a woman in her 40s, and she presents because she has a headache, and it's been going on for several days, and we're just thinking really just of the differential. And so I'm gonna give you a couple sort of prompts for this, and realize that she was in the ED yesterday, now has bounced back and is here, and she presents because she has a headache that's worse in the morning. It gets better when she goes to work and is worse when she wakes up the next morning. She is, it's February, she is living in Winnipeg, we'll say, why not, right? But sort of on the outskirts, and she's living in a trailer, and she is heating the trailer with a device that says for outdoor use only.
I'm suspicious for some carbon monoxide poisoning.
Okay, all right, let's see if our slides are caught up with that. Okay, yes, and your suspicions would be absolutely confirmed. But when you think about it, you know, carbon monoxide toxicity, you're not really going to get that from the onset or the location or the duration necessarily until you start asking some other questions, right? Until you consider that in your differential, asking some other questions like, anybody else at your home have headaches? Or maybe, have you been thinking as clearly as usual? Or do you have a carbon monoxide detector in your house, right? For example. So let me ask you, and this would be, I'll go through this, but I'm not going to belabor it. Can you have carbon monoxide toxicity even after a negative CT and LP?
Yep.
Is it a can't miss diagnosis?
Yep.
Yeah, absolutely. Okay, so, and can we suspect it by just asking questions, by simply talking to the patient at the bedside? Okay, fantastic. All right, excellent. Good stuff. Okay, all right, so question number 2, and I'm gonna bring my little prompt over here. So I have to make sure I got the order correct. Okay, so my next question, well, first of all, what year resident are you? You told me before, but so everyone can know.
I'm in my third year of the 3-year program.
Okay.
Just finishing up.
Okay, nice. And where are you from?
Well, I was from Ontario, but I guess now I'm from Winnipeg, so.
Okay, awesome. I won't tell you the story about the Winnipeg Folk Festival again, don't worry. But at any rate, this same patient who was here yesterday, negative CT and LP, is back, and she tells you that she has some jaw claudication. She tells you that she's had some rheumatologic problems during her life. She has some discomfort at like the temporal sort of area of her head, and she is really still having these symptoms even though her testing was negative yesterday. What are you considering might be going on with this patient?
GCA or temporal arteritis?
Yep, so giant cell arteritis, absolutely. And in the end, if we miss giant cell arteritis, what could happen to this person?
She could go blind.
She could go blind, yeah. And so when you think about it, another thing in the differential is a can't miss type of thing, but unless you've considered that, right, would giant cell arteritis be able to be diagnosed with a CT or LP?
Not a CT or LP, no.
Okay, all right, awesome. And is it a can't miss diagnosis?
Yes, it is.
Okay, all right, fantastic. Thank you so much. Okay, so now we are finally, you're like waited for this whole time. Okay, so we have our third, and this is actually where this scenario came from. I was seeing a patient, and the patient was a patient who had been admitted to the hospital the day before for her headache. And this is my patient. It won't be yours necessarily, but the diagnosis will be the same. But as a patient who had a MRI, MRA, brain, neck, labs, neurology consult, all these sort of things. And she was 40 years old, she was a little bit heavy set, and she was having morning headaches also. And I went in and I used a device that was invented 100 years ago, and I looked in a certain part of her body that I'm looking at you right now, and I strongly suspected this diagnosis. Any thought what this diagnosis could be?
This is so nerve-wracking because I saw the first 2 answers. They had it easy.
So I did a fundoscopic exam, and
Yeah,
I saw
okay,
that.
so IIH?
Yeah.
Yeah.
Yeah, so that's exactly right. So the patient that I had, I literally walked in and used a device invented 100 years ago, an ophthalmoscope, and I saw that she had papilledema, bilateral papilledema. I did a lumbar puncture, and I put the second barrel on. The fluid was about to come over the top, and I diagnosed her with pseudotumor cerebri, or IIH, right? And started her on Diamox. And I sent her home, and then I called the neurologist that had seen her the day before, and I said, "You suck." No, I didn't do that. I did not do that. Bad idea. Do not, as a resident, ever do that. Do not do what I have done. I did not do that, actually, right? But think about it. They sort of did, you know? I mean, like literally after, I mean, maybe it cost less here, but like in the States, like $20,000, $30,000 of this hospital admission, all this testing, and like literally with an instrument that I used, like within 60 seconds of being in the room, I made that diagnosis. Not that I'm so smart, it's like the 90% perspiration type of thing, right? So, and we'll stop asking these questions every single time, but well, we can say with the CT, you wouldn't see it. With an LP, I said sat them up, so you can't really check the opening pressure sitting up, you want to do it laying back. But anyways, is this a can't miss diagnosis? Is this something that can be strongly suspected with your bedside evaluation? Yes, of course. And what happens if we miss this diagnosis?
Also vision loss?
Yeah, so vision loss the same way. Okay, all right, fantastic. Okay, all right, so the next one, we'll pass the mic back down again here. And this is also a patient that I had seen. And the nurse actually did try to talk me out of this because it was a patient who came with a severe headache. She was in her 20s, and she, like, the nurse said, you know, I tried to draw this patient's blood. I mean, this is like a triage lab. That wasn't something I ordered, but I tried to draw this patient's blood, and she's like screaming and hollering, and like she should win the Academy Award for all the like the, you know, histrionics that she's doing. And so like we're just walking in the room, I had this sort of bias that the patient is faking, right? Of course, she's a symptom magnifier. So at any rate, I saw this patient and talked to her, and it turned out that there was something actually going on with her. She actually was with a man who was a IV drug user, and she actually had some seborrheic dermatitis, some bright white vertically oriented lines on the side of her tongue, oral hair leukoplakia. She had some generalized wasting, so she actually had, unbeknownst to her, a diagnosis of AIDS, but she had a real severe headache, and what might be her diagnosis that could be going on?
So I guess I worry about opportunistic infections like toxoplasmosis or cryptococcus.
Yeah, and actually the diagnosis that she had was a cryptococcal meningitis, which you can have a negative LP, interestingly enough, from that. And so that's exactly right. And again, that's something that I suspected based on with her, it was the history and the exam that I did on her. So again, just simply my bedside evaluation. I won't take you through the whole, if you see it on the CAT scan, all that kind of things with this one. The next one, this is sort of like one of those classic board type questions, although I'm never really sure really why this would happen necessarily. I'm going to sort of get it pathophysiologically, but a person walks into some sort of dark theater, they have a fairly sudden-ish type of onset of a headache, it's unilateral, they have some blurred vision, they might have a dilated, hazy cornea.
Acute angle closure glaucoma.
Yeah, right, exactly. And this is another one that, you know, you wouldn't see obviously on a CT scan or an LP, but is a can't miss diagnosis. A lot of these sort of end up with blindness, right? So I won't ask you, that's sort of an obvious one that could possibly happen with that. This next one was actually a case that actually had a lot of play in the United States recently. A friend of mine, Matt Delaney, was one of the defense experts for this case. And it's not the exact case that he had, but a patient who maybe goes to a chiropractor, has their neck adjusted, and then has a sudden onset of a severe headache. You are nodding your head. I don't need to give you any more information. The answer is?
I would go with vertebral artery dissection.
Yeah, absolutely. Some sort of cervical artery dissection, vertebral carotid, whatever it might happen to be. And interestingly, about a third of the time, the headache can precede the onset of the neck pain. However, when you think to yourself, headache and, right, it's always what I think of, headache and fever, headache and confusion, headache and neurologic or focal neurologic symptoms, right, are the things that would sort of prompt you to that, absolutely. Okay, so the next one, and I don't know if you'll know it with this, but we had a certain presidential candidate in 2016 that had a fall, hit her head, and then maybe a month or several weeks later, she developed a headache. She also, not this specific presidential candidate, but maybe the patient that we're presenting here has a history of a DVT when they were younger, and she has some sort of hypercoagulable type of process going on. She has a bad headache, maybe some proptosis of her eyes. She has?
You're talking about like a cerebral venous thrombosis?
Yeah, and I'm so glad that you said that, because like I always just say cavernous venous. I thought that's what the CVT stood for, but you're exactly right. And there's this amazing New England Journal of Medicine review article that talks about that. I think I've sort of got a little bit behind with all of the things that we're putting up here, but that's exactly right. And when you think to yourself, wow, you know, the CT, maybe at half the time you would see it, but you wouldn't reliably see it with the non-con brain scan. And then as far as like with your lumbar puncture, that wouldn't really be helpful at all. But again, unless you suspect, if it's not in the differential, it won't be in the diagnosis for that type of thing. And so that's, again, something that based on, and this is a little bit less history, but maybe some like risk factors or whatever, but you know, thinking about that hypercoagulable with the headache, not having had headaches in the past, that's something really important to obviously include in your differential. Okay, all right. Fatty, we got the next one here is a patient who is, you walk in the room and I told you this woman in her low 40s, she's sitting there with her fiance, they got a cute little baby there who is 5 weeks and 6 days old. That's a tell. And she also, you know, has a elevated blood pressure, 160 over, say, 110. What might be going on with this patient?
Show me preeclampsia.
Yes, show me preeclampsia. So it's a weird thing, isn't this postpartum preeclampsia? Like you'd think like any type of preeclampsia, the solution is deliver the baby, but this baby has already been delivered. But up to say 6 weeks afterwards, we can certainly have some postpartum preeclampsia. That would be, again, one of those can't miss diagnoses, maybe the patient with a headache, maybe some associated abdominal pain, proteinuria, hyperreflexia, ankle clonus, and obviously this is a can't miss diagnosis. And the weird story about this one is soon after I became chair at Mount Carmel St. Anne's, which was one of the big hospitals in Columbus that I had worked at for about 21 years, leaving in 2017 for this new job as with the residents that I work with at my hospital at Adena now. But at any rate, I was actually giving a lecture in Las Vegas about postpartum preeclampsia. I mean, it's one of the cases of a bounceback case. And we had a patient that came into my ED soon after I became the chair, who was seen by one of the PAs who had, I swear, I mean, this doesn't really seem like it'd be believable, but the exact same blood pressure as the one that's in that, you can't really see the colors of the books, but in the blue book, in the medical legal book, case number 6, and was sent home with the diagnosis of migraine or sinusitis or something, and who then was found dead the next morning from postpartum preeclampsia and, you know, the different processes with that. So it was really, you know, terribly tragic case, but it's also because they had not, because it was one of our really great PAs, but they hadn't really heard of that as a diagnosis. So again, if you don't consider it, you're not going to make that diagnosis. The last one, I don't want to take you guys through this necessarily, but a post-LP headache is not a life-threatening, no one's going blind or something from a post-LP headache, but it's sort of a nice thing to think about because, you know, there's certain patients who had this post-LP headache, and we told you the patient did have an LP the day before. So this is like a little bit of an easier one to diagnose. So a couple take-home points from this. We've said it multiple times, number one. Number two, thinking about this before you send the patient home, if they are going to maybe potentially bounce back in 24 hours, what might I have missed? And then account for that. And for folks who listen to MRAP, myself and Amal Matu just a few days ago recorded an episode on documentation about, and one of the things that we talked about, and we also talked about in August MRAP when we did a segment talking about a case of a 15-year-old girl with a headache, but at any rate, we talked about like, yeah, think about those considerations if a patient does bounce back, you know, cold and horizontal in 24, 48 hours, what might I have missed? And then in your medical decision-making note, and this is where I talked about that just a few minutes ago as far as this hard stop process, and sometimes even now, like almost 31 years of full-time practice of emergency medicine, I'll be, you know, dictating in my thing the medical decision-making, I'm like, I'm not really sure I even believe myself on that, right? So you say to yourself, if you don't believe yourself, there's no way that you could convince, you know, a department chair or a family member, peer review. You know, you want to really think about those considerations. Sometimes that might be the thing that prompts you to do one of those 3 R's, the revisit, record, and recruit, where you go back in and get additional information before that patient leaves. When you're thinking about other things, we're going to talk about chest pain a fair amount-ish in the next discussion here, but when you think about localized pain or referred pain, that could be something that throws us off also, right? So certainly you could present, and I just had a case with this recently where the patient had bilateral shoulder pain, which was from acute coronary syndrome, right? So when you think of, you know, patients with that acute ankylosing glaucoma, as you talked about, well, when you think about that, well, that certainly could be manifesting from the patient as head pain. And I have this sort of I'm not saying it's funny, but a little bit of a snarky thing that I think to myself where the patient says, I have a migraine, and I say, no, I'm the doctor, you have a headache, I'll tell you if it's a migraine, right? Again, do not say that as a resident, bad idea. The patient's like, I have kidney pain. It's like, no, you have flank pain. I'll tell you if you have kidney pain. But I say that in a certain way because patients do try to talk us into things, and that happens like all the time. And we are thinking the patients don't want to be sick. We don't want them to be sick either. And I had this patient with a chest pain. I said, have you been sweating? He said, the room was hot, short of breath. Yeah, but I'm out of shape. Listen, dude. You just tell me your symptoms, I'll figure out what's going on. I didn't give him the doctor part, so that was probably a good thing on my part. Okay. In fact, when you think about a non-contrast to number 4 here, non-contrast brain CT doesn't really rule out a whole lot. I mean, stroke, mass, bleed, right? I mean, you know, and it doesn't even rule out acute stroke, right? Because if you have a stroke seen on your CT 2 hours after symptoms, it's probably not what's causing your symptoms, right? So we're doing our CT to rule out hemorrhagic stroke, not to rule in an embolic stroke or thrombotic stroke. So when you think about the CAT scan, it's like, I'm gonna be so cool and get a CAT scan. It doesn't really show that many things when you're thinking about as far as like can't miss 100 things with headache. And so all of this, and you might have heard me say this phrase in the past, but it is an attempt to move from standard of care to excellence in care. You might be practicing the standard of care if you have that patient with a headache and you go in and you do a few things, but boy, wouldn't any of us feel just absolutely terrible if you could have asked that one question and diagnosed carbon monoxide toxicity and not had a wellness check several days later where they found some unfortunate event to occurred in this person's home. Okay, I'm ready for my next set of slides. All right, you guys, thank you. Don't go anywhere. You guys, I'm leaving. So we have some other, I think, which would be pretty fun interactive stuff with this next set here. And then I'm going to be out here at 2:45 if folks want to come out and talk. I have this list of quotes if you want to have that. And then anybody that answers some of the trivia will have the books you can choose between if you get out there for that. Okay, so when you think about bouncebacks, when you think about ER medicine, it's a balance, right? And it's a balance between what I call the 3 S's. I have the 3 S's and the 3 R's. So safety, speed, and satisfaction. And I don't know if you guys do this in Canada. We have this super annoying thing called Press-Ganey scores in the United States. And it's where the patients rate us and how good we were with them. And everything we do, you can certainly game the system. And I heard a doctor the other day said, hey, I'm going to sit down and close the door and explain your symptoms to you. Those are the questions that are asked on the Press-Ganey scale. So, in a cynical way, and certainly I'm no fan of it, but in another way, it's like when you think of speed, it's great if you're writing War and Peace on every single patient's chart, but if there's 40 people sitting in the waiting room with tachycardia, tachypnea, et cetera, that's not really the best thing for your patients. In the same way, your satisfaction is a little bit better when the patient comes through and moves through a little bit quicker. And then safety-wise too, so all these things sort of play on each other. So what I'm doing is I'm gonna give you 10 stories, because all these patients that we see are stories, right? And our chart is the way that we tell that story. And I say this a lot, and for the residents, or maybe everyone here, right, myself included, right? Our chart is an argument. It's an argument for why what we did was reasonable and why what we did not do was unnecessary. And our chart should be logical, and it should paint a picture. And so I'm quoting Amal a lot here today, I guess, but he says, when you're painting a picture, don't be an impressionist, be a realist. When you're reading the chart, you should know what happened in the room. And so I'll give this example later too, but when you think about a 2-year-old and maybe you have a templated physical exam, alert and oriented times 3, right? It's okay, it's sort of a lie, right, for the 2-year-old, and I probably have it on mine too, because you probably didn't really ask them person, place, and time. In the end though, wouldn't you be better served, wouldn't the patient be, wouldn't that chart be much more of a better told story if you say something like, the 2-year-old is running and laughing and screaming down the hall with their parents chasing behind them. I'm not saying that 100% rules out appendicitis. Just saying if you're betting, probably wouldn't bet on appendicitis after you have that type of documentation, right? Okay, so here are the 10 different things. And so what we're gonna do, I think it's number 4, might be number 5. I actually have the actual documentation. I told you, sort of foreshadowed a little bit of this 39-year-old woman, and there's a history present on this, and there's 7 sentences in there. So I'm gonna have this is the next part of your penance. So I'm going to have you each read a sentence, and then there'll be a list of 5 different things to pick between of what that might be. And it's sort of just a way to sort of really demonstrate with an actual chart where there's an adverse outcome, is a way to demonstrate how important it is to actually get that adequate history. Okay, all right, so fair enough. So that comes out, I think it's number 4 or whatever out of the 10. Okay, so this is an actual case, and this is a case of a woman named Stacy. She's a 41-year-old woman, and in all fairness to the doctor, look, you know, she sort of had pain everywhere. I mean, this chest pain clearly was the chief complaint of her, but the pain from above the waist to the head to the neck and arms, I mean, like her left great toe did not hurt or something, you know? So in like sort of a funny, cynical type of way to say it, and I get that. But here's a really important thing with the chief complaint, is to think about, I have to check here. Okay, so you are seeing exactly the left one. Okay, got it. All right, so this is what her chief complaint says. What do you think? Well, I won't ask it to you guys, but of course, what was Stacy asking about when she came to the emergency department? She wasn't thinking she had like Boerhaave syndrome, right? She was worried if she was having a heart attack. That's exactly why she came to the emergency department. But in the end, here was her diagnosis, was hypertension and bronchospasm. And she did have those things. Her blood pressure was significantly elevated, and she did have some wheezing in her lungs, and she was a smoker. And I'll say this, just as far as a little bit of a background, Stacy was like one of these most amazing of peoples. Like, she had a daughter, true story, she was going out with this guy, he got this other woman pregnant, and so he said, so Stacy called her boyfriend's like affair and said, hey, look, have the baby, and I will adopt this baby, which she did, and that was her son. So she had her own daughter and then this adopted son, and so, I mean, she was like literally like the best person. She lived in Texas. This was sort of a famous case. But at any rate, this was the actual chief complaint, and the actual final diagnosis was hypertension or bronchospasm. And in the end, she didn't really have her question answered as far as this concern if this was a heart attack. And that's one of the really big patient safety lessons that I want you to take home from today is, and in all fairness to patients, they might tell their chief complaint to the security person, and then to the person at the front desk, and then to the LPN, and then to the nurse. By the time they get to you, it's like they thought, and understandably so, that it's already been recorded and that it's already been in the chart, right? And in the end, it's like, it's important to make sure that if we can't find that on our EMR, to understand where that is, because it's important to ask that. I'm going to jump ahead a little bit here, and we talked shortly and briefly about the medical decision making, but the medical decision making is our opportunity to have our closing argument. And I told you how I think the chart is an argument, right? That's our closing argument for why, again, what we did was reasonable, why what we didn't do was unnecessary. But take a look at Stacy's medical decision making note. And I'm going to say this in a little bit of a snarky way too. Good job at reviewing the test you ordered, doctor, right? And the other part is like, that's what was done, but it's not a medical decision-making note. It doesn't explain our thought process. It certainly doesn't explain why we don't think the bad things are going on. So what are the bad things that could be going on with the patient with chest pain? I mean, we all know them, but I'm just gonna sort of say, and this isn't like a big thing because I think we all know this, but when you think of the chief complaint, there's really 3 parts of it. The first is the patient's question, and Stacy's question was, am I having a heart attack? But the second question is the question to us, because she's worried about a heart attack, but what are we worried about in a patient who comes in with chest pain? We might be worried about a bunch of things, but I think arguably the big 3 are ACS, PE, and dissection. Those are the really big 3 things that we have to think about with every chest pain patient. And again, more foreshadowing you'll see in this chart that we're going to show in a few minutes, which you guys are going to teach all of us about, right? That those things weren't really adequately evaluated for. Now, 2 weeks ago, there's a study that I was one of the investigators, I designed the study where we looked at the demographics of chest pain. So patients that came in to the emergency department, about 14 million visits, 950,000 chest pain patients. Well, what are the diagnoses of those patients? And the easiest way to think of that for ACS, PE, and dissection is 1 in 10, 1 in 100, 1 in 1,000. It's actually probably 1 in 20, but if you want to just remember it the easier way. So 1 in 20 for come in will have ACS, 1 in 100 will have PE, 1 in 1,000 will have dissection. That was in the American Journal of Emergency Medicine, if you want to take a peek. But at any rate, it's really important to think about because, you know, it's astounding to me, through peer review and some of the medical legal cases that I've done, that those things are not accounted for in the patient's history. And you think to yourself, it's like, there's an expression, there are old pilots and there are bold pilots, but there are no old, bold pilots, right? So if dissection is only 1 in 1,000 patients we see, and just doing the math during our careers, say 30 or 40 years, we'll see 150 to 200,000 patients, about 6 or maybe 7% will be chest pain patients. So about 10,000 patients we will each see during the course of our careers, 10,000 chest pain patients. So we'll each see about 10 dissections during the course of our careers. Now, the math might not be exactly perfect, because if there's like we have PAs and NPs at our ED, so they see some of the lower acuity, so maybe I'll see 20. But anyways, it's not tons that we're seeing during the course of our careers. But in the end, if you don't ask a single question as to dissection, you might end up a bold pilot, but you're probably not going to end up as a old pilot. Because in the end, if you do that, you're really just hoping to get lucky. And you will, usually. Like if you're playing 5-card hold'em, poker, and you had a 99.9% chance of being right, definitely going all in on that hand. But during the course of the career, that's not quite good enough. Okay, so we talked about the chief complaint, these 3 different levels of the chief complaint. The first is the patient's question, and there's another expression that I use, reassurance is a part of healing. So a patient that comes in with chest pain, I mean, any of us, understandably, is super concerned we have something bad or life-threatening going on. They come in with chest pain, it's really nice to give them that reassurance. Hey, look, we, evaluated your history of physical, or we did some tests also if you do that, right? The good news is that, right? So that's an important part of healing, but also an important part that we address that chief complaint, certainly in the diagnosis. The second part is, as we talked about a second ago, our understanding of the chief complaint. The question the patient is asking, am I having a heart attack, in the example of chest pain. The question to us, is this ACS-PE dissection? Or tamponade tension with thorax Boerhaave, maybe plus minus myocarditis, pericarditis, right? The emergent chest pain things, right? But, they're asking us that question. So to me, it feels like our responsibility, again, if we want to not just hope to get lucky, but the third question is the patient's understanding. And so I'm going to give you another example of that. This was a worker. He came in, and I'm going to ask you, because I know you guys have been sort of bored sitting up here, okay? So again, safe space shouldn't be too hard. This is a patient, is a worker, and he came in because he had his arm crushed between a forklift and the wall. And when I say crushed, it was sort of crushed, but it wasn't like hanging on by a tendon. It was like he had some pain. They did a good evaluation. They talked to him for a while. They figured out the mechanism. They did a good exam, neurovascular, got an x-ray, came back negative, and then they gave him prescriptions for pain medicine, and they sent the patient home. So what's the diagnosis that we'd want to consider with a crush injury that might occur later?
Like a rhabdomyolysis or a hyperkalemia?
Yeah, so rhabdo could be one thing, or another thing could be a compartment syndrome. I mean, there's other things too that could be going on. I mean, there could be hematoma that develops, and so there's a lot of things, right? So you're exactly right on that. But in the end, the patient's understanding, and we talked about that with that last slide, the patient's understanding of diagnostic uncertainty is, as been talked about, I think Steve Cluciello, possibly Greg Henry said this first, is the last chance to get it right, is your discharge instructions to a patient. And to make sure that they understand that diagnostic uncertainty. Now, ACEP, American College of Emergency Physicians, has said that in the 2018 guidelines for chest pain is that there is a now acceptable miss rate of 1 or 2% for missed non-ST elevation, ACS, and that's 1 or 2%, because trying to get lower than that number will cause patient harm from false positive tests. And I love that they say that, because for so long we didn't have that acceptable miss rate. But in the same way, it really, in a very, very profound way to me, demonstrates the importance of the patient having an understanding. Because I might have a patient with chest pain and they go home and they break out with profuse diaphoresis. And I'm going to show you this thing that I've been building up so much. I mean, I hope it lives up to its expectations. But anyways, the way that this case ends, we're going to talk about this, literally your heads will be spinning. I promise. It's going to be hard to watch, but your heads will be spinning with what I'm going to tell you how this actually happens. And it's all totally true with this story. But at any rate, this patient here, he had come in by squad. He had a good evaluation. They, put him in the sling. But here's the really good example and how this case demonstrates that this patient did not understand that diagnostic uncertainty, because the patient was discharged home, and the next day, his mom, and he had an appointment with an orthopedist in 3 days, okay? But his mom called the next day, which honestly is sort of sweet that you're a man in his 40s and your mom is calling the ER for you. Mom, it hurts so much I can't pick up the phone. But anyways, it's like a man cold. I shouldn't say that, like it's really bad to say about men, but maybe I can. Anyway, short version is this, is when you think about this patient and he had this pain, mom called, and I know this isn't the main lesson with this, but someone prescribed a different pain medicine. So maybe it was hydrocodone, went to oxycodone, or the reverse. Another day, patient waited at home and then came back and had acute compartment syndrome, multiple fasciotomies, permanent loss of function. The patient was a worker, so was not able to return to work, disability, that type of stuff. So it's really a terrible and tragic case, and in a lot of ways, that third level of understanding, the patient's understanding of the chief complaint, what there could be, or another way of saying it is the patient's understanding of that diagnostic uncertainty, super, super important with the last chance to get it right, making sure that we don't have some sort of miss. And this is an exact example of this. If your pain is so severe, this is something that could develop, the patient would have come back and maybe he wouldn't have had that permanent loss of function, right? Literally one sentence that we say to that person. And a little trick that you can do, and I do this all the time on mine, you know, telling the patient, but then also when you do your discharge instructions, putting not only in the medical decision-making part, but in the discharge instructions, as we discussed, if your pain is worse, return, or changes, or doesn't resolve, et cetera, those types of things. Okay, all right, point number 5. You guys actually are point number 6, so you guys getting ready? Okay, all right. Okay, so this is a story of a patient by the name of David Likens. You can look him up on the Google. He lived in Dayton, Ohio. He was a battalion chief, he was like a firefighter, took care of patients. And he came in, this is when there were written charts, although there maybe are not that many of those anymore. Still, you need to find the chief complaint and the patient's information in your huge AMR, and if you miss it because you can't read it or can't find it, it's sort of the same thing. So, okay, so we are to you now. Okay, will you do me a favor? Tell me what you can read there. Complains of?
Chest, shoulder, pain. Maybe.
Yeah. Okay, I know, I took it off of yours and it's up on here now. Complains of left shoulder pain, something, something. Symptoms started yesterday afternoon. And this is sort of interesting too, that little X on the top under WC is wheelchair. This is a 41-year-old battalion chief who is like a big, strong, hulking man. He's seen by one of the PAs. He has shoulder pain, hurts when they move his shoulder. He got an x-ray, don't really love that for non-traumatic pain, but whatever. And then he asked the physician about the patient. He asked the physician to go in to see the patient. The physician saw the patient, actually wrote a note also, and then the PA, physician assistant, called the primary care doctor who said, quote, and it was documented in the chart, the patient tends to overreact to his healthcare needs. And they sent the patient home. So concern, 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 all of a sudden, not concerned at all. Okay, so what happens next is the patient gets in the car with his wife, and they're going to the pharmacy to pick up some pain medicine for his severe shoulder strain, because he'd been lifting patients the day before. Another phrase, association does not equal causation, right? He'd lifted patients for the last 20 years. But anyway, it wasn't causally or temporally related, that lifting, to the onset of his symptoms. So anyway, they stop at a gas station to pump gas, and his wife gets out to pump the gas, and he gets out, lowers his pants, and urinates on the gas pump. So there's a French phrase, and if anybody could tell me that, we'll do our first little trivia book giveaway with that. You can pick a book. 3-word French phrase that might explain what was going on. Yes, la belle indifference. That's what you said, right? Close enough, okay. I mean, right. I'm like talking to the French speakers here, right? Okay, I know a little medicine, but not as, you know. But anyways, that was what you were intending to say. So come out there at 2:45 and we'll get you to pick out a book. So they later, and this is a legal case that I went to, did a deposition. You can look this up. Please read slowly so I can understand. Complaints of left shoulder pain, chills, and fever. So wow, thinking about documenting your own malpractice, this patient had a documentation that he had a fever, but yet he was diagnosed with a shoulder strain, and that wasn't accounted for. Now, I will say sometimes I'll ask patients, do you have a fever? And they say yes, and I'll say, oh, you mean a temperature over 100.4 degrees? And the patient says, oh, no, doctor, nothing like that. I have a headache. And I'm like, what? That doesn't make any sense at all. And actually, so I was doing this residency lecture at like UPenn or UPitt. It was something, it was in Pittsburgh anyway. And this guy came up to me afterwards. He says, well, I used to work in West Africa, and actually the word for fever is headache, or the opposite. I'm like, oh, well, maybe that's why they said that. Although honestly, with my patient, I don't think that that's why they said that. But it was sort of a funny thing when I did that lecture and they sort of corrected me in that way. But anyways, the point is this, is like, you know, asking that follow-up question is like so important, isn't it? You know, the follow-up question with David might have been, you were lifting patients yesterday. Was it any different than the day before? Did your shoulder pain start suddenly when you lifted a patient? Or did it start later that night? Which still could have been from the lifting, but just we don't have as much confidence. And then in conjunction with fever, that's another thing. So what happens with this patient is the patient is discharged home. During the night, his wife gives him pain medicine. In the morning, or in the middle of the night, she calls the primary care doctor and says, man, my husband still got this severe pain. And she says, the primary care doctor said, well, if it's that bad, go to the ER, but if not, we'll see you first thing in the morning. So they did go in there first thing in the morning, had a big bruise on the left side of the chest, went to the ED, heart rate 140, blood pressure of 70, had a necrotizing soft tissue infection, had actually not really neck fash, but necrotizing myositis. And in the end, they went back and looked at the, not just the ER record, but the urgent care that sent the patient to the ER, pain out of proportion, tachycardia, hypotension, and not a great mechanism, and there were some other things too. And in the end, unfortunately, the patient expired 2 weeks to the day of him coming back to the ED, or as to his first visit in the ED. And you could read about it, it's all public information. David Likens was his name, a terribly tragic case, but a case that maybe with just a little bit of additional information, or making sure that our chart did tell that cohesive, logical story. Okay, so you guys have been very patient, thank you so much. But now we are finally to this part here. I'm going to tell you another story, and this is a story about a woman by the name of Anna. And Anna lived in Cleveland, Ohio, a true story. She was married, she had 3 kids, they were really into baseball. She worked as a waitress at a restaurant that's like a diner like off the highway, and she was a warm and caring person. She was a little bit overweight, she was a smoker, she drank 6 beers a day. Here's her whole chart. You don't need to read this whole thing, obviously. But at any rate, she every year got bronchitis. She went to her primary care doctor in September, and she said, I have bronchitis, and she got a Z-Pak, so azithromycin, if you call it a Z-Pak, yeah, right? And awesome. So that antibiotic is great for killing viruses. So at any rate, that was September, and then in November, she wakes up one morning, and she has chest discomfort, she vomits, and she tells her husband, I'm gonna go to the emergency department. And he says, do you want me to come with you? And she says, no, you stay here, get the kids to school. He says, fine, but I'm not gonna go to work, I'm gonna wait here until you get home to make sure you're okay. And so, so that's what happens. So she checks in the emergency department sometime just before 5 o'clock in the morning. And this is the exact documentation from the physician. So here's what we're gonna do for our little game here, okay? And we can just sort of start here and go through. Unless, no, we should start at the end. We'll just keep it fair. Okay, so I'm gonna have you guys read each sentence. There's 7 sentences. And then I'm gonna have you pick from, is this a chief complaint, history of present illness, past medical history review systems, or something else? And I will say this, it's totally fine in that history of present illness section to put things like past medical history and social and family and all those type of things, and I do that all the time. And I'll just give you an example of that. If you think of a patient, a woman in her 40s who has breast cancer, that was diagnosed a month ago, so there's her past history, super important to know about. She's presenting with fever, super important to know that she was just diagnosed with breast cancer, and super important to know that a week ago she got chemotherapy, right, or whatever, 5 days ago, whatever, now she has a fever, right? Those are really important things to know, but that's the past medical history, and the history of present illness is description of the fever, of course, right? You know, what's the height of the fever? Do you have a headache? No, just kidding. But you know, is the fever something that's been amenable to antipyretics? I mean, all the different things. How long have you had the fever? Okay, you get where I'm going, right? Okay, so all right. So this patient came in, Anna, she checked in, and this is the exact documentation, nothing's been changed. Chest pain, coughing, and vomiting. This is case number 1 in the blue book of the Bounceback books. Okay, so she has chest pain, coughing, vomiting, those are chief complaints. Could you please read me the first sentence? You can just read it out loud. This patient is A.
Under HPI.
Yeah, under HPI.
The patient is a 39-year-old female who approximately 1 month ago started developing a cough and congestion.
Okay. So that's something that happened a month ago. What do you think of those 5 choices? What is that from? What is that?
If it happened a month ago, then it's past medical history.
Absolutely. And see, I told you the safe space. I wasn't going to be like hard questions that were going to embarrass you guys, even though you did not have the answer on the screen for that one, but doing great. Okay, so yeah. So we got some little bit more past history, so we know a little bit more about this patient. Okay, all right. How about sentence number 2, please?
So she was seen by her primary care provider and started on an antibiotic.
Okay, what do you think?
Also past medical
Yeah,
history.
something happened a month ago, important to know about, but it's something that happened a month ago. Okay, 2 sentences in, 5 to go. Patient's presenting with chest pain. We got to roll out the bad stuff, but okay, sentence number 3.
She started improving, but after going off the antibiotics, the cough came back, and she's been coughing up yellowish sputum.
So it's sort of a combination of 2 things, right?
Past medical history and HPI.
Yeah, exactly. So now we finally know something about chief complaint number 2. We know that her cough is productive, and we know that the color is yellow. We don't know how much she's coughing. We don't know if she's been exposed to ill people. We don't know if there's hemoptysis. There's still tons of stuff we don't know. But I mean, for God's sakes, at least we know a little bit, finally, about chief complaint number 2. Still don't know anything about chest pain, but I'm a glass half full guy. It's all going to happen. I've got faith. Okay, sentence number 4, please.
Okay, almost lost it. She had post-tussive vomiting today.
Okay. So history of Presenolis.
Yeah.
Yeah, okay, sorry, those are the choices. I knew that's what you were thinking here. And so, right, so now we know a little bit more about chief complaint 2. We know that at least one time after she coughed, she vomited. We know something about chief complaint number 3, that she, at least one time when she vomited, she coughed before it. But again, we don't know, does she have diarrhea? Is she lightheaded? Is she dehydrated? Exposure to ill people? Like a million things we still don't know about that. But at least we know something. But do we know anything about the chest pain yet? Is chief complaint number 1, right? You have faith like I do? We're going to get it all? Okay, all right. Fingers crossed. Okay, sentence number 5, please.
All right, so she indicates that when she coughed, she gets very sharp pain in both the front of the chest and the back.
Okay. So
it could be related to her chest pain, but more kind of related to the cough. So
right.
I guess like review of systems, kind of history of presenting illness.
Right, yeah, so it's sort of both of those, right? So if you think in all kindness, and you guys I know are never going to invite me back how mean-spirited I'm being with this like criticism, this person who's not here to defend themselves, right? But we now finally know something more about the chest pain. We know the character, that is sharp. We know the location, front and back, and we also know that it's worse when she coughs. So sort of pleuritic-ish, right? Okay, all right, so 2 more sentences. Sentence number 6, please.
Those are the symptoms that she has been having.
Okay.
You
guys are all mean-spirited. It's not just me.
Something else.
Right. If you were J.K. Rowling's editor, probably strike through there, huh? Yeah?
Probably, yeah.
I'm just saying, like, I don't usually have tons of extra time on my shifts, I haven't used the bathroom in 2 hours. Like, you don't really want to put extra stuff that's not necessary. And then sentence number 7, please.
She denies any fever or shortness of breath, and that is review of systems.
Yeah, for sure. Okay, so let me ask you this. I can ask each of you guys, ACS PE dissection, have we ruled out ACS with this patient?
No, I don't think so.
I mean, not really even close, right? And if I told you that she had exertional chest pain the night before, and that her brother died of an autopsy-proven MI at the age of 35, would you be a little more concerned?
Just a bit.
Probably get an EKG on that patient, okay? All right. How about as far as PE? And when you think about PE, when you think about PE, the patient is a smoker over the age of 35 on birth control pills, and she sort of has a pleuritic-ish type of character of her discomfort in the sense that it hurts when she coughs. Maybe that's not like completely, perfect, but do you think we've rolled out PE with this patient?
Not rolled out, no.
Okay, all right. And you get where I'm going with this one here. Yeah, so you can probably answer before I ask the question, right? But I'm not going to ask you the question you think I'm going to ask you, am I? Yeah, that'd be too easy. So take a look. Well, you can look here, or if you can read it, it's sort of small. But take a look at chest. She's tender over the anterior chest wall, but how about over her back? Yeah. Have we ruled out aortic dissection?
No.
No, we haven't. And I like this case because it's not esoteric, it's not obvious, and it's the sort of kind of case that any of us might have handled it the same sort of way, because it really seems like acute bronchitis where you strain your chest wall muscles. But there's a couple things in there that just don't really make sense. Like, why does a woman, why does the 39-year-old woman come to the ER at 5 o'clock in the morning? She probably didn't think she was like, having acute viral bronchitis. As well, she did have the pain over here, but not over the back. Maybe that act of doing that hard stop in the medical decision-making note would have been, here's why I don't think ACS, PE, and dissection would have prompted us to do a couple additional things. Usually, the prompt is to gather additional information. Okay. So what happened to the patient, and this is the part I told you was going to make your head spin. She's discharged home. She gets home, and her husband says, I'm going to go to work. He goes to work. He comes home. She fixes dinner. And he says, how you doing? She says, I'm still not feeling that great. The antibiotics haven't kicked in yet. Okay? So they have dinner. She and her husband and the 3 boys. They are startled to hear her, when she walks in the kitchen, fall to the ground, water glass crash into the floor, rush in to find her unresponsive. Husband calls EMS, and he says, I think my wife choked on a piece of chicken. She was in the ER that morning. She was in the ER that morning for chest pain, and she collapses that night. He was so assured that level 3 of the chief complaint, the patient's understanding of the question being asked, the patient's understanding of some diagnostic uncertainty, that was so missing with this case that even after she collapsed, and he told them again that when she got to the emergency department, I think she choked on a piece of chicken. They find her in VFib, they shock her, they intubate her, they take her to the ER, they're unable to resuscitate her, and the next day an autopsy shows a complete occlusion of the LAD, as well as, interestingly, from when she went to her primary care in September, a organizing clot in the septal area. Okay. So super tragic case, but really simply with getting additional information, at least it could have prompted us to get an EKG, which I'm guessing probably, we don't know for sure, probably would have been positive at that point. This next case here, story of Peggy, is one I was telling you about from the one that Amal and I did in August. Quick point of clarification, I got 707 on here. Is it still that? Or 5? Okay, perfect. Okay, so the story of Peggy is a 15-year-old girl who lived with her grandmother. She had development of a headache, and as it turns out, her headache was so severe they couldn't get her to the car to take her to the ED, and so they called the ambulance, the EMS, and they took her to the ED. When they got to the ED, she was in so much discomfort they couldn't even get her from the EMS stretcher onto the cart to examine that patient. But take a look at the documentation here. Patient denies it his worst headache ever. So think about that. I mean, to me, it feels like CYA having that type of documentation. But in the end, man, this is sort of crazy, isn't it, right? In what world is the 15-year-old girl's headache where they can't even get her into the car and they have to go by EMS and they can't get her from the cart into the bed? In what world is that not the worst headache ever? And so they actually had some deposition testimony. This case actually went to trial, and here's how this sort of played out. And you can just sort of look in the minute. And is it fair to say that grandmother's version is not consistent with the documentation? Yes. It's fair to say that she was at one point severe pain and screaming, yes, sobbing. That's not noted in the chart. So just because we put something on the chart, there's other people that are there that see what happens with this patient. I have an expression that I also used, you might have heard me say, a good history is free, but a poor history can be expensive, and that expense is really the expense to the patient as far as not getting an accurate diagnosis. Take a look at this documentation. There's so many words here, like good job on the quantity, but in the end, this is a dialysis patient, frequent flyer with chronic abdominal pain, and this patient came in with abdominal pain to the ED. The only thing we know about the abdominal pain, location, character, similarity to past discomfort, severity, all these different things. The only thing we know is that it started that morning. She's whining, that they say, you'll see that in the physical exam part, that she wants something for pain. She has vascular problems. She's just had an ischemic limb recently. She's like faking, in other words, putting her finger down the throat, spitting into a basin on the side of the bed. Very poor historian. Interestingly, the documentation in the second from the bottom row. In the end, we're the historians, right? We're the documentarians. The patient might not be able to give it history, but we're the ones that give that history. We're not transcriptionists, we're documentarians, we're historians, right? Okay. So at any rate, what happens with this patient is she's sent home after they speak with the nephrologist, although the nephrologist didn't really know exactly what was going on in the ED, comes back the next day and was seen by the night shift doctor, ordered a bunch of tests. I took over at 6 o'clock in the morning, and when her test came back, she turned out to have mesenteric ischemia, or really mesenteric infarction. Her whole colon was dead. They took her to the OR, opened her, closed her, and she was dead in 6 hours. But again, just another example of how that bedside data gathering, why we went into medical school, right? Not me, but you guys, right? You know, can be so, so important as far as making a diagnosis. All right, our final thing on the 10, then we're gonna have a couple other trivia questions. We'll end in 2 minutes, I promise. Wouldn't you feel better if? We talked about the example of the 2-year-old running and screaming down the hall. Here's what they documented with that chronic frequent flyer end-stage renal disease patient. She's whining consistently about wanting pain medicines, and now we know why. Because she had severe pain because her entire colon was dying. In the same way, with a patient who is having chest discomfort and you think it's musculoskeletal, wouldn't you rather say something like in your documentation, when I palpate the left lower sternal border, the patient exhibits facial wincing, withdraws from pain, yells, ouch. That doesn't prove that it's musculoskeletal, but it goes a lot farther than just simply saying musculoskeletal chest wall pain. That's that really important thing that you can document with that. Okay, so a couple other trivia questions. You guys can just, it's gonna be maybe obvious. And the reason I put this person's picture up because he was one of the greatest describers of things ever. And so that's part of the physical exam part here. And you can just yell it out. Yeah, you already get a book though.
Okay, okay. No one heard.
No one heard. Anyone know who this is? All right, good. All right, I'll meet you out there at 2:45. And the reason I like to put is that this is his typewriter, his six-footed cat, because he just is so good at describing things, and we can all use him as a role model. Who's this man? All right. Whoever thinks they answer first, come out and meet me out there at 2:45. All right. So in the last 30 seconds here, the really big take-home points for this: making sure patients understand diagnostic uncertainty, making sure a chief complaint correlates with the question being asked, making sure that a history is the actual history of the present illness, right, as these guys showed us so importantly, documenting our physical exam objectively, using that medical decision-making as a hard stop, and then most importantly, I don't want you to take anything away that we should be practicing defensive medicine, but more so that we should be evaluating and documenting in a way that is defensible. So thank you again so much for having me, and look forward to talking to y'all later. Thanks to you guys. You guys are done. Thank you so much for coming up.
Thank you so much for this and for what I think is one of the most important books for your careers. If anyone wants to approach a microphone and have any questions for Dr. Weinstock, you can entertain him for a couple more minutes. I'll start us off by just asking a couple of things. How have you seen the evolution of your career over doing so much work that involves or revolves around medical, legal, and quality assurance?
So to me, it feels like the stuff that I've done, not only just medical legal, but also peer review, has made me such a better doctor because you can anticipate it. That sort of front door, back door approach that we talked about earlier, anticipating what could be going on and then accounting for that. So really important concept, the chart doesn't have to be a huge quantity, but it should be quality. As far as the medical legal part, there was a case we had just recently, it's still ongoing. We spent I was on the defense, the plaintiff attorney, 30 minutes discussing the meaning of one word, which was acute. And when you think about, does acute mean sudden? Does it mean something new? Does it mean something that wasn't there before but now is there, and in what period of time? Acute sinusitis, it's not like it all of a sudden starts, right? So thinking about the words that we use, if there is an adverse outcome, and as far as really justifying and really furthering the argument that we're making in our documentation in the chart.
Okay. I have another question, a follow-up of sorts. When you're looking at AI scribe documentation, are you finding that you're missing far fewer of the most important things that when people are doing this by themselves?
So AI Scribe, I have mixed feelings on it. I use it exclusively in November, December, just to really get good at it. And I felt like for me, it wasn't really capturing what I wanted to capture. And the nice part, like my wife is a primary care doctor, I think, she's got these long notes because they have all these different things and chronic medical problems. A lot of times the stuff that we're doing is pretty brief. It might be the medical decision making 2, 3, 4, 5 sentences, right? Because you're sort of explaining why you're doing that, why you don't think the bad things are going on. It didn't really feel to me like the AI Scribe that I use. Now, of course, it's probably like 18 generations further now than it was in December. And I think it will eventually get to that point. And there's ways to train AI Scribe too. And patients might like that, to say something like, I've considered these things, and I don't think they're going on for these reasons. And then AI Scribe will put that in your note. So as it keeps evolving, it's going to learn about us, we're going to learn about it, and it's going to get better and better. I think it saves some time. It probably saves a lot more time in primary care than it does in emergency medicine. That's just my own sort of thought.
Feel free to approach the microphone if you're back there. If not, scream out from wherever you are if you're feeling like you don't want to get up. What's that? Sure. So anyway, we'll welcome any of you to approach Michael at the table where he will have some of these books, and you can continue to ask any questions there if you wish. Anyway, thank you very much again.
Thanks again, Sean.